Dear all, welcome to Focus on Aseptic Safety in Breast Patient Care. My name is Teija-Kaisa Aholaakko. I am PhD in Medical Sciences, Licentiate in Educational Sciences and Registered Nurse, specialized in perioperative and intensive care. My research interests have long been in intraoperative aseptic practices and teaching it on evidence base. This presentation is the first of two presentations focusing on enabling safe breast cancer patients' pathway from the surgical site infection prevention and control points of view. This first part introduces the main concepts in the microbiological safety, the overall patient and procedure-related risks to surgical site infections in breast surgery. The second part discusses critical aseptic incidents crucial for all the professionals working in the breast cancer patient's pathway. In part 2, the aseptic practices in breast surgery model serves as a structure for the practical implementation of the infection prevention and control measures in the breast patient's pathway. Learning outcomes. After the two presentations, the learner is able to demonstrate critical knowledge of aseptic safety in breast surgery patient care, ability to implement patient and procedure-specific infection prevention and control measures in breast surgery patient care, ability to guide the breast surgery patient and personnel to prevent, follow up and report surgical site infection-related outcomes. Some words for background. The breast cancer patients in this project expected to have comprehensive and timely guidance and information related to their upcoming breast cancer pathway, enabling them to prepare themselves for what was to follow. The patients mentioned the outcomes of the breast surgery as positive experiences after their surgical procedure and lack of follow-ups as negative experiences. The healthcare professionals defined the competency of healthcare professionals performing surgery, trust on healthcare professionals, and clear information given to the patient of different aspects of the surgery, the key factors related to a successful breast cancer pathway. According to the USAMA, the breast patient's preoperative path of the care pathway consists of several hospital visits, discussions with multidisciplinary team members and nurse counseling for diagnostic and surgical procedures. Our retrospective patient chart survey revealed breaks in patients' pathways, particularly in infection prevention and control documentation, follow-up and feedback. From the infection prevention and control points of view, the ability to argue patient information with evidence-based knowledge and the awareness of the cancer patient's whole perioperative process are key competencies in safe surgery, performed by all professionals working on the pathway. The critical use of local infection prevention and control data collected by hospital infection surveillance systems or professionals is important due to the biases in the local pathways, circumstances and resources. It is important to prevent the biases by structured follow-up measures. Now we are focusing on definitions. First, definitions by the EU Council. Adverse event is an incident which results in harm to a patient. Harm implies impairment of the structure or function of the body and or any deleterious effect arising therefrom. Healthcare-associated infection means diseases or pathologies related to the presence of an infectious agent or its products in association with exposure to healthcare facilities or healthcare procedures or treatments. Patient safety means freedom for a patient from unnecessary harm or potential harm associated with healthcare. Process indicator means an indicator referring to the compliance with agreed activities such as hand hygiene, infection surveillance, standard operation procedures. Structure indicator means an indicator referring to any resource such as staff, an infrastructure, or a committee. Healthcare-associated infections as a threat to patient safety. According to the European Disease Control and Prevention (ECDC), healthcare-associated infections are infections acquired by patients during their stay in a hospital or another healthcare setting. Although some of these infections can be treated easily, others may more seriously affect on patients' health, increasing their stay in the hospital and hospital costs, and causing considerable distress to the patients. The most frequently reported types of healthcare-associated infections are respiratory tract infections, surgical site infections, bloodstream infections, and gastrointestinal infections. Definitions for surgical site infection by ECDC. Superficial incisional infection occurs within 30 days after the operation, involving only skin and subcutaneous tissue of the incision and at least one of the following: purulent drainage with or without laboratory confirmation from the superficial incision, organisms isolated from an aseptically obtained culture of fluid or tissue from the superficial incision, and at least one of the following signs or symptoms of infection: pain or tenderness, localized swelling, redness or heat, and superficial incision is deliberately opened by surgeon unless incision is culture negative. Diagnosis of superficial incision made by a surgeon or attending physician. Deep incisional infection occurs within 30 days after the operation if no implant is left in place, or within 90 days if implant is in place and the infection appears to be related to the operation and infection involved deep soft tissue, fascia, muscle, of the incision, and at least one of the following: purulent drainage from the deep incision but not from the organ or space component of the surgical site. A deep incision spontaneously dehisces or is deliberately opened by a surgeon when the patient has at least one of the following signs or symptoms: fever more than 38 degrees centigrade, localized pain or tenderness, unless incision is culture negative, an abscess or other evidence of infection involving the deep incision is found on direct examination, during reoperation, or by histopathologic or radiologic examination. Diagnosis of deep incisional surgical site infection made by a surgeon or attending physician. Organ or space infection occurs within 30 days after the operation if no implant is left in place, or within 90 days if implant is in place and the infection appears to be related to the operation and infection involves any part of the anatomy, organs and spaces, other than the incision that was opened or manipulated during an operation, and at least one of the following: purulent drainage from a drain that is placed through a stab wound into the organ or space, organisms isolated from an aseptically obtained culture of fluid or tissue in the organ or space, an abscess or other evidence of infection involving the organ or space that is found on direct examination during reoperation or by histopathologic or radiologic examination. Diagnosis of organ space surgical site infection made by a surgeon or attending physician. Risk factors for surgical site infections. According to ECDC, in European countries, the patient surgical site infection risk index is the index used in the US National Healthcare Safety Network and assigns the surgical patients into categories based on the presence of three major risk factors: wound contamination class, ASA classification by American Society of Anesthesiologists, and duration of operation. The maximum sum of scores is 3, and the calculation follows. The score is 0 if the wound contamination class equals 1 or 2, ASA classification equals 1 or 2, and the duration of the operation is less than 75th percentile cut-off value in hours. And the score equals 1 if wound contamination class is 3 or 4, ASA classification equals 3, 4, or 5, and the duration of the operation is more than 75th percentile cut-off value in hours. The maximum sum of score is 3. The wound contamination classes are described as follows. Wound class 1. A clean wound is an uninfected operative wound in which no inflammation is encountered and the respiratory, alimentary, genital, or uninfected urinary tracts are not entered. In addition, clean wounds are primarily closed and, if necessary, drained with close drainage. Operative incisional wounds that follow non-penetrating trauma should be included in this category. Wound class 2. Clean contaminated wounds are operative wounds in which the respiratory, alimentary, genital, or uninfected urinary tracts are entered under controlled condition and without unusual contamination. Specifically, operations involving the biliary tract, appendix, vagina, and oropharynx are included in this category, provided no evidence of infection or major break in technique is encountered. Wound class 3. Contaminated wounds include open, fresh, accidental wounds. In addition, operations with major breaks in sterile technique or cross-pillage from gastrointestinal tract and incision in which acute non-purulent inflammation is encountered are included in this category. Wound class 4. Dirty or infected wounds include all traumatic wounds with retained devitalized tissue and those that involve existing clinical infection or perforated viscera. This definition suggests that the organism causing postoperative infection were present in the operative field before the operation. Generic risk factors for surgical site infections. In addition to the classical surgical site infection risks, also more detailed procedure and patient-specific risks have been reported in several studies. Patient-related risk factors for surgical site infections include age, male gender, nutritional status of the patient, diabetes, smoking, obesity, coexistent infections at a remote body site, colonization with microorganisms, altered immune response, length of preoperative stay in hospital, medication, hypothermia, reduced blood flow following hemorrhage, reduced subcutaneous perfusion and oxygenation. Operation-related risk factors for surgical site infections include preoperative skin preparations, preoperative shaving, skin antisepsis, duration of surgical scrub, duration of operation, antimicrobial prophylaxis, operating room ventilation, inadequate sterilization of instrument, foreign materials in the surgical site, surgical drains, surgical technique, poor hemostasis, failure to obliterate dead space, tissue trauma, emergency of the operation, or operating room traffic. Surgical site infections in breast surgery. Breast operations cover a variety of surgical procedures from local excisions to mastectomies without or with immediate or delayed reconstructions, each having a patient and procedure-specific consequences to breast-operated patients, particularly surgical site infections. The surgical site infection risk index makes the risks-related outcomes clearly visible. After mastectomies, the surgical site infection rates reported as 2.07% in risk index category 0 and 1, and as 3.97% in risk index categories 2 and 3 respective. In large-scale breast surgery outcome studies, the expected surgical site infection rates in these clean surgery operations reported between 2 and 4%. In the US, the surgical site infection rates in breast surgery are traditionally reported varying from 1 to 2%. These rates are lower than in Europe or elsewhere outside the US. Varying from 0 near to 20. This may be due to weaknesses in postoperative follow-up, quality problems in perioperative care, or variation in the patient and procedure-related risks. From this table, surgical site infection rates and risks in breast operations are clearly visible according to the risk index categories, according to the diagnosis of the operations, and whether the implants or reconstructions are completed or not. Reoperation as a surgical site infection risk in breast surgery. The risk for surgical site infection after reoperations is reported significantly higher than after primary operations in several studies. In our retrospective register-based survey, reoperated patients had 2.6-fold, 2.4-fold, and 2.7-fold risk for surgical site infections compared with primary operated patients among all operated patients, local excision and mastectomy patients respectively. In a US cohort study, the surgical site infection incidence was twofold higher after mastectomy with immediate reconstruction than after mastectomy alone. Only 49% of surgical site infections were detected within 30 days postoperatively. In a study of Throckmorton and Associates in 2009, there was no statistically significant association between prior operation within 90 days and surgical site infection rate. Procedure-specific complications in breast surgery. Axillary lymph node dissection is a classical procedure often completed as a reoperation requiring an additional incision with underarm location. In a Cochrane review, axillary lymph node dissection is reported resulting more likely lymphedema compared with sentinel lymph node biopsy with no significant differences in overall survival of the operated patients. Full axillary clearance without clinically and radiologically involved axilla is no longer considered acceptable practice. A recent study challenged the high costs and long operative time of standard procedures by suggesting possibility to avoid intraoperative frozen section in most cases of early-stage clinically and radiographically node-negative breast cancer patients without a significant impact on the overall quality of treatment and standard of care. Procedure-specific complications in breast surgery. Breast reconstruction has a positive impact on the body image and quality of life for women after experiencing the physically and psychologically demanding processes. But the positive experience may be threatened by post-operative complications. Impaired wound healing 18.3%, seroma 6.1%, hematoma 4.6%, capsular contraction 4.6% and infection 3.8% reported existing after breast reconstruction operations. Postoperative complications 3.1-fold surgical site infection rates or impaired healing, 3.8-fold surgical site infection or impaired healing requiring surgery reported due to the implant used as a temporary spacer for delayed immediate autologous reconstruction compared with no spacer. The explantation of the implant occurred after 16.3% of procedures. Other risks for complications were the surgeon, higher drain volume during the last 24 hours, higher implant volumes, higher resection weight, and incision type. In a study of Alves et Associates published in 2022, no significant differences reported in hematomas, infections, flap necrosis, and in partial or total flap loss between immediate and delayed deep interior epigastric perforator flap operations, but higher prevalence of wound healing issues, healing delayed, dehiscence, and superficial skin necrosis in delayed breast reconstruction probably linked to complex care process including radiation or chemotherapy interfering the healing process. Surgical drains as infection risks in breast surgery. After breast operations, patients usually have one or more surgical drains, removing bleeding and leak from the surgical site. The criteria for drain removal vary. Some surgeons remove drain according to the postoperative day, some by drain volume, per day, and per patient-defined criteria. Drain volume is reported varying according to the surgical interventions and techniques used. After the subcutaneous placement of breast implants or expanders after a mastectomy without biological matrices or synthetic meshes, the drains remained for a mean of 5.9 days, producing a mean cumulative volume of 458.3 milliliters with the mean volume of 16.7 milliliters with the last 24 hours. The association between the high drain volume during the last 24 hours and explantation of the breast implant was reported statistically significant. In our study, the existence of surgical drain predicted 3.3-fold risk for surgical site infection among all breast-operated patients and 3.2-fold risk was among local excision patients. Among mastectomy patients, the risk was not statistically significant. Variations in measuring patient-related surgical site infection risks in breast surgery. In a recent US study, the variation in surgical site infection rates reported in association with chronic obstructive pulmonary disease, COPD, diabetes, smoking, ASA class severe, body mass index more than 35 kilograms per square meter, and length of hospital stay more than 1 day. Body mass index over 25 kilograms per square meter was reported as a risk for surgical site infection in lobectomies and mastectomies. Body mass index over 30 kilograms per square meter was not reported as a risk following implant-based breast reconstructions. In a large-scale studies, the body mass index over 35 kilograms per square meter, in addition to smoking and diabetes mellitus, were reported as surgical site infection risks in lumpectomies and mastectomies. Examples of surgical site infection risks in breast surgery with debatable evidence. The breast cancer patient's preoperative hospital visits include invasive interventions like core needle biopsy and placements of a wire or other localizing device prior to the surgical procedure, challenging the requirement for intact skin in the operational site, but not having clear association with surgical site infections. In our past study in lobectomy and mastectomy patients, nurses reported the skin of the patient in the surgical site intact for 80% of the operations and signs of preoperative infection in 6%. Nurses documented preoperative invasive procedures in 55% of the operations. A sentinel puncture was completed in 10% of the operations, wire marking in 35%, and other punctures, for example blue ink application, in 3% of the operations. The rest of the patients had anesthesia-related punctures. The evidence related to the risk of preoperative invasive procedures is not free from bias due to the challenges in retrospective data collection and documentation. Conclusions. Securing aseptic safety in breast operations is important due to the variation in the numerous general, patient, and procedure-related surgical site infection risks. It is crucial to further develop procedure-specific process indicators enabling the implementation and measurement of patient, occupational, and environmental aseptic safety in breast surgery. The implementation and follow-up of procedure-specific infection prevention and control measures require relevant structure indicators and evaluation models validated in breast surgery. Here some references for your further use. And more references. And I am Teija-Kaisa Aholakko. I thank you for your time. And here is the Ebreast2 consortium. Thank you all.